few more minutes to see if we can put people on the line. So thank you for your patience. Let's get started here. I did want to first of all welcome everyone to this presentation. We are going to be recording it, and we will provide a link to this session as well as the material itself. It will be posted on the ICD-10 website. At the end of this presentation, I will be sending that out to everyone, but also through the WebEx chat that you have immediately available. Save that as a favorite. So kind of an overall view of this session. Part of the ICD-10 program's documentation assessment effort, we want to provide a series of specialty-specific presentations that are focused on your particular area of interest. The session is focused on the OBGYN specialty. We have other presentations that will focus on other medical and surgical specialties. So if you have an interest in attending those, you are more than welcome to do so. Invites and the dates of those sessions are also housed on the ICD-10 website, so we do encourage you to check that out. I will go ahead and turn it over to our presenter, Alan Frady. He does a much better job at introducing himself than I do. So please, go ahead.
Thanks for the introduction, Nathan. My name is Alan Frady, and a little bit about myself. I'm a registered nurse primarily in CS, cardiovascular thoracic surgery and recovery. Some stuff. I've also been a case manager and a full-time coding auditor and coding director. For about the last 5 years, I've been doing documentation improvement. Really, for the last year or two, I've been working on ICD-10 preparation, like many of us. And generally, when we're talking about coding and CDI, we don't really look at OB that much, but it's hard to talk about the transition to ICD-10 without stopping and focusing a little extra attention on the OB chapters, because there are some significant changes that I think have the potential to impact coding and documentation and sort of how we've done things in the past. So with that, we'll go right to this. Sorry, two screens, and I have to activate the right screen here. Start with how we look at the coding and the different diagnoses for a normal delivery, and you can see that not a lot has changed. We used to use the old 650 code rarely, but we use it for just a normal delivery. And here we have for ICD-10 an encounter for full-term uncomplicated delivery. Our outcomes are very similar. I'm going to talk a little bit more about the outcomes in the next slide. And also have these different groupings. For example, encounter for cesarean delivery without indication. That should never happen. That should be a code that we should never have. We would always know the indication. Here are the outcomes, and you can see quite a few more on the ICD-10 as opposed to the old V codes. And again, we have the twin versus the multiple, the triplets, the quadruplets, the sextuplets. This is going to be pretty standard in the documentation. I don't think we'll have any trouble capturing these outcomes. For pregnancy coding guidelines, we're talking about postpartum and peripartum periods. The postpartum period begins immediately after delivery and continues for 6 weeks. And after that 6 weeks will be, most of the time, will end up going in as just a regular medical diagnosis. The one exception to that has traditionally been postpartum cardiomyopathy, which is just a one-off, and that's a diagnosis that continue to given and continue to be coded for even years after delivery. That's the one I know of that really works that way. One complication is any condition occurring within that 6-week period, And we call these Chapter 11 codes, maybe used to describe pregnancy-related conditions after the 6 weeks, whenever applicable, and we'll look at some of those examples if you ever get that type of assistance. And postpartum complications that occur during the same admission as delivery is you just regular code, but the digits change, and that's not all that different than how we've been doing it, and this is sort of how we've been doing it in ICD-9, really. So questions for pregnancy, childbirth, etc. Is the provider to document if a condition being treated is not affecting the pregnancy. So, generally speaking, when a coder looks at a chart on a pregnant patient, anything wrong with that patient is going to end up going to a pregnancy code. And we can do that for just about anything. I mentioned cardiac. We can do it for endocrine. We can do it for viruses, illnesses, high blood pressure. Even things like injuries, sometimes they'll be tempted to put pregnancy with other specified manifestation on there. So if it's something that is really, truly incidental to the pregnancy and the pregnancy is incidental to that, it's the responsibility of the provider to document that it is not affecting the pregnancy so that diagnosis can be pulled out of the combination code. We're going to presume it's related. Trimester is really the big talking point when it comes to OB. That's something that we haven't traditionally had to capture in ICD-9, and now we've definitely got nailed down, whether it's the first, second, or third trimester. I see this as an area that we could potentially have queries to the physician. If the doctor writes, the doctor's not very clear about the exact trimester or the exact number of weeks. So, for example, if they use months instead, or it's a very short stay and it's kind of vague, I could see that generating queries. What they consider to be the trimesters, again, fewer than 14 weeks, 0 days, first trimester, 14 weeks, fewer than 28 weeks, second trimester, and then 28 weeks until delivery, third trimester. Is pretty straightforward there. And then this chart showing that there is a difference, even in ICD-10, between episode of care and trimester. Not all codes in pregnancy for ICD-10 are broken down by trimester. So if the trimester is not a component of the code, it's usually because the condition always occurs in a specific trimester or the trimester is not applicable. And I'll show you examples of those. For example, can show up either in the second trimester or the third trimester. We want to avoid these unspecifieds. And I know it's always been a rule, but in general, we always end up using unspecifieds for everything. And with ICD-10, there's been a big panic that we couldn't use any unspecified at all. That has not turned out to be true. There are a lot of unspecified codes out there that we probably will end up using, but not in the OB. We should definitely be able to nail this down and get it on an inpatient stay and definitely figure this out. So we should never have to use 06.00, obviously. So here are some examples. Examples of characters available. We've got gestational edema, first trimester, second trimester, third trimester. Then you have where it's not applicable. So you have for abnormal coast, it's just going to use that sort of the old ICD-9 nomenclature. Complicated pregnancy, complicating childbirth, or post-delivery. And you have where it's not available. And for example, failed inductions, it's not applicable because we assume those are all third trimesters, so it's not a component of the code. So you do have that variation. Your points with hypertension, if it is a non-pregnancy, we need to know if it's essential, secondary, if it's due to kidney disease, or if it is caused heart disease. We need those combination codes. Hypertension and kidney disease is always a talking point in standard CDI, so of course we have it here for our pregnancy patients too. How it's unique to the pregnancy, we just need to know if it's pre-existing or gestational. That'll be really the key piece that they're going to be looking for. Is this gestational hypertension or was this a pre-existing? Because it does change the coding. Excuse me. Preeclampsia. The documentation for preeclampsia should include, again, was it pre-existing or gestational? What's the type of hypertension? And how severe is it? Is it mild, moderate, or severe? And what trimester is it occurring in? And then we've got the HELP syndrome if present. And the same goes for eclampsia. Again, what's the severity, what's the trimester, and did it occur during or after delivery? Diabetes. In the three categories, is it during childbirth or postpartum? And we need to know if it's diet controlled, insulin controlled, unspecified controlled, if it's type 1 or type 2, pre-existing or not pre-existing. Those are all, and that's pretty standard documentation. You're probably already putting that in the charts now. It's just for the coder's sake that these will be coded slightly different. Examples of the codes. And this is not even really the pregnancy code. This is what 648 is abnormal maternal glucose, so it is pregnancy code, excuse me. Complicating pregnancy. And on the right side, you have all of your options: diet controlled, insulin controlled, unspecified, and so forth. And then down the bottom is it postpartum, intrapartum, prepartum. So you can see quite a few more codes here on ICD-10 to use from. A lot more specificity. I'm sure you're probably all tired of hearing about that, but it's true. There is more specificity here in the pregnancy and pretty much in everything. Coding guidelines for ICD-10. Gestational diabetes can occur during the second and third trimesters. Diabetic prior to pregnancy, it puts women at greater risk. You all know this, of developing future diabetes full on. And we always need to pick up, not necessarily have a type 2 diabetes, a pregnancy-induced diabetes, and they can still be insulin requiring, which is not necessarily the same thing as insulin dependency. But if they're insulin requiring for more than a few months, we may use the long-term current use of insulin. If they're requiring insulin to manage an acute illness, so for example, they've got a UTI, something's going on, they got to go on insulin for a week, we probably would not use this code. This has to be a sustained requiring insulin long-term, more than a few days, more than a couple weeks. Codes are important. For example, the Z9.4 goes into your risk adjustment, which actually helps to separate the patients who have a high cost of care, high length of stay, and frequent readmissions from the patients who aren't expected to have those type of outcomes. So even a code like long-term current insulin goes toward that risk adjustment and helps you with your profiling, your quality, your base purchasing. So the things that we tend to minimize and we don't very much are very important to get right and to get on the charts. Coding comparison between gestational diabetes and got on the left is other current conditions and mother classified elsewhere but complicating pregnancy, and on the right we've got gestational diabetes, insulin controlled. So I think the documentation will be there to capture this. It's really going to be just a difference for the coders here. Diabetes versus gestational. So here's your pre-existing, which would be the E10 diabetes without complications, and you have your O24 at 0.01 pre-existing diabetes type 1 in pregnancy first trimester. It would require two codes, and you'd put the pre-existing in pregnancy first, and then the standard diabetic code second. And then the second example is showing gestational diabetes, insulin controlled, which is type 1 necessarily. Pre-existing, this is very similar to what we just saw. You see the two codes that are required for the pre-existing. You've got the pregnancy code and the type. To show the Z code, the Z79, whatever it was, code for the long-term current use of insulin. If it's type 1, that risk adjustment is assumed in the coding already, so you only have to add that, really, what they're saying here, you only have to add that if they are a type 2, whether or not they're insulin for long-term. Again, you will automatically get a combo code where it affects the pregnancy. And during pregnancy and childbirth, patients admitted because of HIV-related illness, that actually may end up code subcategory O98.7, complicating pregnancy, childbirth, or the postpartum. And then you would have to add the additional codes for the HIV and whatever infectious conditions that they had. Placental disorders, your documentation for placental disorders should contain, of course, the trimester. I think we've established that. And things like fetal placental syndrome, placenta previa, ruptio placenta, and also if there's any coagulation defect, hopefully not DIC, but if there's any coagulation disorders, we can add that separately. Here in the placental transfusion syndrome, you see these examples again. Fetus, fetal maternal, what type of transfusion syndrome is it? And down at the bottom you have your placenta, is it with or without hemorrhage, we would need to know. a suspected or known variation, we need to know exactly what it is. And here's some examples: CNS, chromosomes, anti-D antibodies, what trimester, other rhesus antibodies, what trimester, we need to know those, other isoimmunization, fetal damage from maternal bowel illness, alcohol use, other maternal medical procedures. That can be captured and significantly impacts your risk adjustment. You have known or suspected fetal malformation from hydrospitalis. You have a intrauterine death here. You have excessive fetal growth, decreased fetal movement, so on and so forth. Well, I'll go here. Of course, as always, we need to know the trimester. Or unstable eye. You've got your transverse, face, brow, high head, compound presentation, so on and so forth. And most of the time, the charts I've seen over the years, this will be documented because it'll be significantly impacting the care when they're admitted for delivery. Maybe not always. If it's like a false labor and they're not expected to deliver for a while, you may not see these things because the baby could shift, obviously. But I think the documentation for these is usually there, and it's usually done pretty well. Presentation, you've got your outlet issues, you've got your mixed maternal and fetal issues, you've got your other fetal deformities, and so on and so forth. Other maternal complications. So that will not require a code for the trimester could be malpresentation. Here we've got 032, maternal care for malpresentation. It's a condition associated with delivery and is not applicable in the first and second trimester. So again, we're not going to be able to capture that as part of the code. It's going to be assumed to be the third trimester for things that are going on at the time of the delivery. You can see those here. Using for the physicians, what I would say to do is just get in the habit of always writing the trimester on your charts, and then that way you don't have to stop and say, well, is this one of the codes that's impacted by trimester, or is this something that's assumed to be during the entire pregnancy, or something that's only assumed to be at the time of delivery? Rather than going through that whole process, it might be easier to just get in the habit of just writing the trimester at least somewhere in the chart one good time, so that it's all there, and then you don't have to do additional analysis. For amniotic fluid, for amniotic fluid and membranes, documentation again here, these do impact the trimester: chorioamnitis, infected amniotic sac, and of course multiple gestations, which I've got some slides on coming up, I think. Hopefully you've never run across these, or if you do, it's very, very rare, but these also would require the specific trimester for things like amniotic embolisms, thromboembolisms, septic embolisms, fat embolisms. We have a lot of other things that sometimes are overlooked on our pregnancy patients, and do have a lot of impact sometimes on the D or G, but sometimes on adjustment. So even something like varicose veins, thrombitis, hemorrhoids, malnutrition, obviously. Excessive or weight gain is usually on the chart as part of high-risk pregnancy, usually. Infections, usually documented if it's a delivery case, but not always if it's not. Dependence, even a simple UTI. Acute anemia, something we don't typically get from OBs because we're dealing with, 20, 25-year-old, maybe 30-year-old healthy women. They may have a 2 or 3 point, but treat it, it's going to self-correct in a couple of weeks, so you don't end up getting the acute blood loss anemia, and I understand that. If it's more significant, what I would say is if it's an hour above what you typically see on an average, what you would have expected, then go ahead and write the acute blood loss anemia. You don't necessarily have to give the transfusion you have given it if it's a healthy patient, and you're just going to monitor. That additional monitoring that you're going to have to do, even post-discharge, will justify the diagnosis. I would say in those cases, you're probably safe to go ahead and add it. And then, of course, you have your multiple gestations. Pregnancy complications, again, this list continuing. Liver disorders, peripheral itis, spotting, retained IUD, that would probably be on the chart. You get definitely get all the specificity with the AI or the CKD and what stage it is. Any kind of, like if they're having diabetic manifestations, that would also need to be very clear. or not it was pre-existing or not would need to be clear. Just sort of a visual form of what we just covered. You've got your fetal malformation on the left, fetal damage from the maternal in the middle, and then other on the right. Just get an idea of how this breaks down in the codes. All right, gestations. Document the multiple gestation concepts as following: the trimester, the number of fetuses, and how many placentas and amniotic sacs are present. I don't recall ever having to do that in ICD-9, but the code is very confusing for the coders when they're trying to figure this out. But if you'll put these things down, it will go a long way towards helping them. ICD-10 uses terms of how many fetuses and whether they're monoclonic or monoamniotic. If it's not possible to determine how many placentas, just usually, I think at the time of that should be obvious, should be able to get that. So other codes that are impacting pregnancy in terms of risk adjustment, expected length of stay, and other codes that you may see in the office, again, would be how many weeks of gestation, what's the outcome of delivery, whether it was additional postpartum care, that could be like in your office post-op. And the pregnancy state needs to go on every chart of any pregnant patient. It's going to tip the coder to try and figure out if he or she should use the pregnancy combo code or just a standalone diagnosis code and the encounter coding. In labor, over the years, I've seen this very well documented. Things like D cells, oligohydramnios, I can't talk today. Fetal distress. Usually those things are all on the chart and they're very well documented. What we sometimes do have a hard time with is the meconium, whether or not it was meconium aspiration, whether or not it was below the vocal cords, and we have a lot of clinics that tell us when we can use that and when we shouldn't use that, and so we have to know if it was just in the oral airway or down below the vocal cords. And fetal distress, usually we get that pretty clearly. Some tell if there are kinks in the cord or problems with the cord. It's hard for us to tell if there was truly a compromise to the circulation or it was just twisted, and so sometimes that can be a problem. We're looking to see if it's a true kink or a true knot when we're doing those cases. Abortion, fetal death, and the time frames. The time frame for differentiating the abortion and fetal death has changed from 22 to 20 weeks, so we lost a couple of weeks there. And the time for differentiating early and late vomiting in pregnancy has been changed from 22 to 20 weeks, so that's interesting. And the preterm labor is defined as anything before 37 weeks, I believe was the way we always did it in ICD-9. Slight change there. That's more for the coders and trying to figure out which code to go for or maybe what type of query to ask, and this changing is important. For outcomes, the study is pretty much unchanged. We need to know if it was, in other words, if it was spontaneous abortion, if it was complete, incomplete, unspecified, and we're going to be looking to see if it was without hemorrhage or with or without shock or any kind of additional complication in those cases. We'll be looking to see if this was an induced termination, a induced termination, a spontaneous, a molar pregnancy, that sort of thing. Usually found over the years, those things have been pretty well documented. Skip over one of the talking points, which I think is interesting, is that they have removed the legal versus illegal from the terminology. That's no longer part of the quote-unquote lexicon. It's just what type it was medically, into whether it was illegal. And I don't know that I've even ever used the illegal, or anybody has, that really, in many, many years. So that's probably why it was removed. So, again, for your Board of Outcomes, some additional complications. I mentioned the bleeding and the shock already. Will any kind of genitourinary tract or pelvic infection, embolisms, venous complications, renal failure, metabolic disorders, and so on and so forth. We're going to be looking for those things. Those are huge impactors on the stay. And the most common things that we'll look at for complications above and beyond what the laceration issues are, whether it's a first, second, third, fourth degree, and what depth of laceration and how deep the repair. That's probably the most common, is that one. It's so common, in fact, that I'm not even sure we mentioned it in the presentation because we assume everybody is on top of that. But next to that, it would be these things. Electrical CCs and MCCs, and I'm not familiar with these terms. CC is a patient who's a little sick, and an MCC is a patient who is very sick. So, and if they don't have either an MCC or a CC on the chart, it's usually assumed that it's just a standard care. It should be a very short stay, low cost, and very, very low risk of any kind of readmission or complication. So in order for your risk adjustment to really reflect a sicker patient, you would need either a CC or an MCC, depending on whether they're moderately sick or severely sick. So that's kind of what these terms are designating. So for a CC would be perhaps your acute hemorrhagic anemia, genitourinary tract infection, mild preeclampsia. Your third and fourth degree lacerations would count here. And then your MCCs would be things like full-on eclampsia, the amniotic cavity, obstetrical embolism, obviously shock, obviously severe preeclampsia, obviously placenta preview with hemorrhage. Those obviously would be the very sick patient. I don't think we're going to have a problem capturing that from the chart. It's usually the CCs that we are there, or we may have to query. A lot of times, especially with OB, the MCC is very apparent, and you can kind of pick it up, and you don't have to ask for it unless it's something like acute staph, which you shouldn't have in this patient population. So with that, a little quicker than I had anticipated. I didn't really do any discussion, but we have quite a bit of time left over to open this up for discussion. Any questions, comments? So I think Nate will probably mute everyone, and we'll see if there's any questions.
Yes, Dr. Sam. On the CCs that you have, there's no patient delivered when the patient's already delivered.
And sometimes what we run into with CMS is that their complication doesn't necessarily match clinically with what we would consider to be a complication. What they've done is they have just a one-off question. After we close, sometimes as soon as we stop, somebody will get a question. Feel free to get in contact with me, probably through Nathan, and we'll address those. I believe we're doing this presentation again. Is that right?
Put me on the spot for when that is, but I know it's going to be, we will have a repeat session for those who are unable to this session. So I did want to call out that in the chat for the WebEx, I've just provided the link to the ICD-10 website. Not a great wealth of other information, but the schedule of all the remaining sessions, nature, the repeat session for this OB specific, that schedule is also listed there as well. So anything of interest, please go ahead and sign yourself up for that.
And tomorrow between 9 and 10.
Tomorrow between 9 and 10. Thank you, Rainey.
I'll check back over to Nathan if there's no further questions, and we can wrap up and close out. Thank you, everyone.
Thank you, Alan.